Good evening, doctors. Welcome to 52 Weeks Diabetes Essential with Dr. Sanjay Kalra. As you know, sir, with last 2 weeks we have been discussing about testosterone and diabetes. Then we discussed about PCOS and diabetes. Now, in today's new session, Dr. Sanjay Kalra, who is a topmost endocrinologist of India, is going to discuss today on fertility and diabetes. So before I hand this over session to Dr. Sanjay Kalra, I would like to announce the winners of the last episodes. And now I hand over the session to Dr. Sanjay Kalra, sir.
Thank you, Mr. Basu, and good evening, everybody. It's the second Sunday of the year. We've begun last week with a discussion about female aspects of diabetes, polycystic ovary syndrome, and before that, we had talked about male aspects of testosterone. Let's move on today. We'll continue with the same series, and we'll talk about fertility in diabetes. Now, see, reproduction is an essential part of being human for any race, for any species. Without reproduction, the species will not be able to survive. So, sexuality is important, so is reproduction. Another word for reproduction would be fertility. And yet another word that is used in gynecology is fecundity. So, today let's talk about fertility in diabetes. Now, let us make one thing very clear. In persons with uncontrolled diabetes, there may be fertility issues. But in persons with controlled diabetes, well controlled diabetes, there should be no issue at all. So that's quite clear. Even otherwise, one third of the reproductive age group population is supposed to suffer from some form of subfertility or the other. That is one third, which is quite high. So if you have a person who is living with diabetes, who is well controlled, and is subfertile, we can find non-diabetic causes as well. So we should be aware of this. But still, people with diabetes will come to you and they will say, Dak Sahab, can I get married? Will I be able to have children? The answer is yes, of course, why not? And then another question will come, Dak Sahab, I'm already married. Now can I have children? I'm worried about my HbA1c. I'm worried about what will happen to my children. So let's see the answers to these and more. Now, there are many risk factors related to infertility and diabetes in women. First is menstrual abnormalities. It can be amenorrhea, it can be oligomenorrhea. In fact, very famously so. And just yesterday, I completed 25 years in endocrinology. So, our professor used to say that the commonest cause of amenorrhea, apart from pregnancy, is uncontrolled diabetes. It used to be that bad 25, 30 years ago. And you may find it funny to believe, but just 40, 50 years ago, one of the treatments for women with type 1 diabetes was lifelong abstinence. That was part of the prescription. We don't have to worry about all these things now. And you may feel that 40, 50 years ago is so long ago, but actually it's not so long ago as well. So menstrual abnormalities are common. It can be amenorrhea, it can be oligomenorrhea, sometimes increased bleeding. But shortening of the reproductive age group is certainly there. So in girls with poorly controlled type 1 diabetes, there may be delayed menarche. And there is premature menopause in both type 1 and type 2 diabetes women. During the reproductive age group, if there is poor glucose control, there will be complications, acute as well as chronic. In acute, some of the complications include pruritus vulvae, which might prevent sexual intercourse. Other STDs can occur. So, poor glycemic control may hamper fertility by hampering contact between husband and wife. Secondly, chronic complications like micro and macrovascular complications. These also are a risk factor for subfertility. When we are speaking of chronic complications, one of the microvascular complications is neuropathy. Within neuropathy, you have painful neuropathy. And in our OPDs, we have so many patients who present with painful neuropathy, usually of the feet, of the lower limbs. But there is a syndrome known as vulvodynia. That means pain in the vulva. And this is a form of painful diabetic neuropathy. So your patient may present with sexual dysfunction. Within sexual dysfunction, your patient may present with pain disorders. So do take a history of dyspareunia and also a history of vulvodynia. The vulvodynia may be due to diabetes and poor diabetes control, and the treatment will be similar to that for painful neuropathy. Now, hyperandrogenism or polycystic ovary syndrome is another factor that is associated with dysglycemia. Both are associated with each other. In case diabetes is autoimmune, it may be associated with other autoimmune disorders of the ovary, that is, premature ovarian insufficiency, of the thyroid, hyperthyroid or hypothyroid, of the adrenal insufficiency, though that is not so common, and all these may impact fertility. And sexual dysfunction, like we've said, it may be a pain disorder just because of a pruritus vulvae, or dyspareunia, or vulvodynia. And it may be a desire disorder. It may also be a disorder of orgasm. So, all these are risk factors, and in general, they are all related to poorly controlled diabetes. Of course, our fertility rates are improving markedly now, and things are much, much better than they were 20 years ago. But still, even in developed countries, like in Sweden, for example, the overall fertility in type 1 diabetic women is about 20% less than in non diabetic women. So, about let's say 16 to 20% less. And we should be especially aware of retinopathy and nephropathy because during the preconception phase, it is important to check for albuminuria. It is important to do a fundus examination. Whatever treatment is to be done for the fundus, for retinopathy, and whatever treatment is to be done for albuminuria should be done prior to conception. The reason is that retinopathy may worsen during pregnancy, so we should fix it before we start planning. And secondly, for albuminuria, we have very good drugs available. ACE inhibitors, ARBs, finerenone, all these are contraindicated during pregnancy and during conception phase. So we should give them, control the albuminuria and stop them, shift to other antihypertensives, and then move on with pregnancy planning. So we should be aware of all these. If your patient has high blood pressure, then do remember to give the safer drugs. Amlodipine, cilnidipine, these would be good examples of safe drugs. You can also use lebitalol in uh, relatively mild hypertension. Another safe drug for severe hypertension would be uh, arcamine, which can be used. So these are other things to be aware of, that the routine therapy for retinopathy, for nephropathy, and for hypertension will not be valid, will not be safe in people who are planning pregnancy or those who are pregnant. In general, when we think of uncontrolled diabetes, we think of type 2 diabetes and we think of heavy women, polycystic ovary syndrome. But at the other end of the spectrum, also, there can be subfertility. So, there is a disease known as anorexia nervosa. Anorexia means lack of appetite. Nervosa means nervous. It means it's a functional disease. There is no structural abnormality, but there is such a severe fear of gaining weight that the person stops eating food even though she is feeling hungry. This is associated with hypothalamic dysfunction and it can lead to amenorrhea and infertility as well. A lighter version of anorexia nervosa. We don't see anorexia nervosa so frequently in the OPD. I see maybe once a year, twice a year. But a lighter version is orthorexia nervosa. And I see more and more patients presenting with this. Ortho means upright. Orthorexia nervosa means a nervous fear, a functional fear, preoccupation with the food that I'm eating. Am I eating the right food or not? So the patient, every time when they eat food, they will begin to count calories, begin to count carbohydrates, begin to look at the food label, and just keep on counting the food, and they will lose all the enjoyment of eating. That is quite common in both boys and girls, in men and women. Another situation which is even more common is called boarding school amenorrhea. And this happens when girls go to boarding school, to hostel, or when they are exposed to stressful condition. This I see very frequently in girls who are preparing for entrance exam for NEET and for NEET PG. So they get disturbed periods. That is also because of hypothalamic dysfunction. The pulsatile secretion of GnRH is impaired. GnRH is gonadotropin releasing hormone. And when this is impaired, then the release of LHFSH from the pituitary gets impaired, and that impacts their feedback on the ovary. So anorexia nervosa, bulimia nervosa, right at top, very severe, not seen frequently. Orthorexia nervosa being seen more and more frequently. And third is boarding school amenorrhea or stressful amenorrhea, which is quite common. All these have an impact on menstruation and also on fertility. In athletes also, there is something known as an athlete, female athlete triad syndrome, and they also present with amenorrhea or oligomenorrhea. There's a new name for it now. It's called Red S, which is relative energy deficiency syndrome. Red S is the same as athlete amenorrhea. Only thing is you can use Red S to define to include men as well because they also have the same thing. So it is a relative energy deficiency syndrome. We have spoken of type 1 diabetes, we have spoken of relatively lean ladies so far. So you have a picture in mind now how infertility is occurring or how subfertility is occurring. But let's go back to the beginning of the spectrum, and that was obesity. So, obesity, diabetes, insulin resistance, polycystic ovary syndrome, all different but overlapping conditions, all have the same risk factors, and all are associated with alteration in menstruation and alteration in fertility potential. Sometimes we do this test called AMH, anti Mullerian hormone. AMH is a marker of oocyte reserve. How many eggs are present in the woman? So each woman is born with something like 4.5 lakh eggs. But most of them get die, they get destroyed because at the end you just need one egg per month. So let us take 30 years of reproductive age. 30 into 12 is how much? Roughly 450. So you need roughly 450 eggs only. How many eggs are present? For that, you will do a test called AMH, anti-Mullerian hormone. This is quite frequently advised in women, who are maybe 27, 30, 34 years old. And they say, can I postpone marriage? Can I postpone pregnancy? I want to know my fertility potential. So we do AMH. The point why we are raising it here is because AMH can be falsely high in women with polycystic ovary syndrome. So in PCOS, when you get the AMH done, you may get a high report or an upper level of normal report, and that may make you complacent, the clinician and the patient both. So be aware that in PCOS, AMH is relatively high. It's a false high. And this brings us to the point that we have to manage patients. So apart from all the routine testing that is to be done for subfertility, do remember to do a hormonal status. Usually, LHFH testosterone are LHFH estrogen are not required usually, but you may need a testosterone. Very, very rarely you will get an LHFH done. If FSH is high in a young lady, it means it is premature ovarian insufficiency if it is more than 25. Also, you should check for thyroid. You must check. Good idea to get a TSH ultra sensitive done. The lab will take extra care. And if it is even borderline or there's a family history of thyroid, do not hesitate in getting thyroid antibodies done, anti-TG, anti-TPO. Because if they are high, then your targets will be different. You will have to keep the TSH below 2.5 and you may need a small dose of thyroxine, even if the patient is supposedly euthyroid. Anti-ovarian antibodies are also done in practice in infertility centers. I myself do not do, but AMH is something that we do. And hyperandrogenism. We must do a serum testosterone and do a clinical examination for hyperandrogenism. So acne, hirsutism, acanthosis nigricans, all these we must look for. When you're managing hyperandrogenism, the first thing to ask the patient is, are you planning a family or not? If they are not planning, then we can give many drugs, including uh, menstrual regulators. But if they're planning pregnancy, then we don't have too much of option. Then we do laser therapy, and also you can use metformin, which is approved for use before and during pregnancy as well, in polycystic ovary syndrome as well as in diabetes. So, fertility issues, do a good testing. Apart from what is being done routinely, order a testosterone, thyroid test, AMH, and if required, antibodies. Also, apart from what you are doing routinely in the OPD, do be more careful while taking a history of sexual function. because sexual arousal and lubrication, these will be issues, pain will be an issue. And if you handle these, you will actually be pleasantly surprised. The couple will be rewarded with a pregnancy. Again, remember that menopause can occur earlier in women with type 1 diabetes, also in type 2. So, in poorly controlled type 2. So, do not be very complacent when you see a normal AMH. Try to tell the patient to complete family by the age 35. Above 35 is defined as elderly primary gravida. And the more the age, the more the chances of chronic complications, including nephropathy and retinopathy. Especially for retinopathy, it is a duration dependent complication. So even if you give excellent control, after 20, 30 years, there will be some amount of retinopathy. It's a part of aging. So it's a good idea to complete family as soon as possible. Now we have spoken of women, but the point will come, what about men? And even in men, glucose control is important because the sperm depends upon glucose metabolism. In persons with hyperglycemia, sperm motility comes down and sperm number may also come down. Patients may also have pyospermia infection. So you will have oligospermia, asthenospermia, that is weakness, reduced motility, and maybe pyospermia. All these are common in persons with diabetes. There is an epigenetic impact also, and it is said that um, men whose wives conceive when those men are hyperthyroid, their children may be at higher risk of getting metabolic syndrome later on. So it is a good idea to control diabetes both in the men, in the male partner, and in the female partner. You should explain to both the partners that it's not just about what is happening today. If you have poor glucose control, you will have poor fertility. But it's also about what's going to happen next. It's called transgenerational karma. Transgenerational karma we have traditionally used for women, but there is research to show that it is applicable for men as well. So there is epigenetic modification. That means the gene is the same, but the protein structure is changed by poor diabetes control. There can be methylation, for example. There can be breakdown, for example, acetylation. So acetylation, degradation, all these things can occur, and that impacts the structure of the function, which impacts the structure of the sperm, which impacts the function of the sperm. And this change in structure is passed on through the male germ line. So the boy who is born of such a pregnancy where the father had high diabetes will also have a higher risk of diabetes. So this, if we are able to explain, and the concept transgenerational karma is very good. It's also good to explain that whatever baby is going to be born is a sum. It is 50 plus 50, both mother and father. So why will the father's glucose control not have an impact? That should be answered, not the other way around. If we are able to do this, we'll be able to convince our patients about what we are doing. And the main aim is glucose control. So that's the single take home sentence that we would have. First, fertility can be impacted in persons with poorly controlled diabetes. Second, this is true for both men and women. And third, we can make a difference if we ensure good glucose control pre-conception and during conception, and of course after conception, in both partners, in both the male and the female partner. This is an important message we should give to our patients. And what you must have seen in your clinics also is that now diabetes is occurring at a younger and younger age, and people are planning their pregnancies at a later and later stage. So you will see more and more of these complications, more and more of these clinical situations as you go on. So with this, I'd like to thank everyone, and we look forward to questions and comments.